Kumar, let me know when we start.
Sir, நான் இங்க தான் சார் இருக்கேன். I can start anytime.
Okay.
5 members இருக்காங்க.
Sure. Okay. Clear இருக்கு சந்திரகுமார்.
Thank you, sir.
Okay, shall we start? Muthukumar sir.
Yes, sir. We are waiting.
Sir. Okay.
We are ready, sir. The narration, we know that already there.
Okay.
Both of them are waiting. Dr. Dharmaraj also has come. I welcome all the three of them.
Okay.
And,
Right, now we are on live YouTube also, sir. I sent the link to the groups.
oh, that's
It
very
is
good.
there in the chat box also. If some of the doctors want to join, you can share the link with them.
Sure. That's a very good thing.
Because some of them have Zoom issues, personal, private issues.
Okay.
So some of them will go for the YouTube. So Saturday.
Was the last time, was it used by people last time when the public forum happened?
Public forum, there were 68 members in the Zoom meeting. And YouTube, 14 of them.
14, okay.
And Facebook, our IMA Facebook page, there were 6-7 members.
Okay.
Most of them staff and their relatives. Okay, so now there are 30 people, sir. We can start the meeting. Let them join.
Yes, sir.
So good afternoon, friends. Indeed a great pleasure to welcome you all to this November CME, supported by Parvati Hospital. And I call the meeting to order. Let us begin the deliberations with IMA prayer. I request our Vice President, Joint Secretary Dr. Gunashekhar, to help us with the IMA prayer and the physician prayer. Dr. Guna?
Yes, sir. IMA prayer. May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the healing cure beyond every greed and loot. Physician prayer. Dear Lord, thou great physician, I kneel before thee, since every good and perfect gift was come from thee. I pray, give skill to my hand, clear vision to my mind, kindness and sympathy to my heart. Give me singleness of purpose, strength to lift at least a part of the burden of my suffering fellow men, and a true realization of the rare privilege that is mine. Take from my heart all guile and worldliness, that with the simple faith of a child, I may rely on thee.
Thank you.
Thank you, sir.
So we lost two of our members during the last month. So it is our one Dr. Santosh Kumar Tiwari, young medico doctor. He studied MBBS at Stanley Medical College. Was a famous general practitioner in around Selayur and Madampakkam. So lost his life fighting COVID on 17th October 2020. So he's survived by his wife Anita Tiwari and his kid Pranav Tiwari. So on behalf of IMA Tambaram, we offer our heartfelt condolences to the young family and pray that his soul rest in peace. Another tragic event happened on 30th. One of our members, Dr. Jyoti Lingam, he and his son met with an unfortunate accident in his native place. And he was a cardiothoracic surgeon working at Omandura Medical College, and his wife, Dr. Kavita, is a private practitioner in our area, practicing at Sri Sarvesh Clinic, Ropet. He is survived by his daughter named Srinika, again a young family. So let us all pray and pay a silent homage to these two departed souls. So we'll pay 1 minute homage to these two members. Thank you. So may their souls rest in peace. So it's my pleasure and privilege to welcome all of you for this November CME. So on behalf of IMA Tambaram, the managing committee, I welcome Dr. S. Muthukumar, Chairman Parvati Hospital, and thank you, sir, for supporting this CME.
Thank you, sir.
On latest trends in orthopedics. I also welcome the speakers for this day, Dr. T.K. Vinod Kumar, Dr. Naresh Kumar, for this CME. Thank you for joining us, and we look forward to your talk to learn about the latest trends in orthopedics. Also welcome Professor Dr. Chandra Kumar, who is the Project Director of National Program and Control of Blindness in Tamil Nadu. He's been doing a wonderful job the last few years, strengthening the national program in Tamil Nadu. But here he is on a different platform to talk to us about the health insurance for doctors, we know we seen many of our members really suffering during the COVID season, particularly when the members, the earning doctors are get affected with COVID. The families really had a difficult time supporting their family as well as the raising cost of health. So I'm sure this initiative of him through the TNGDA, Tamil Nadu Government Doctors Association, which has been extended to the private doctors as well, will be useful to all our members. Also happy to welcome Dr. Madhavan, the Secretary of Tamil Nadu Ophthalmic Association, and currently the FSS Secretary of IMA Tamil Nadu State Board. Thank you for joining us, sir. We look forward to your valuable inputs towards learning about FSS as well as the healthcare support aspects of FSS. I'm happy to welcome Dr. N. Gunashekharan. Most of us would know him as the former general manager of TTK and Vidal Healthcare. He has readily agreed to share this platform with the two other eminent specialists here to tell us about the health insurance and how it will help us and our family during the difficult period when some of us fall sick. So I also welcome all the senior members, the former presidents and members of managing committee, and all the IMA Tambaram members who has joined this CME and also who are yet to join the CME are looking in the YouTube link. So welcome to this CME. So October was the COVID season was really coming down, so not much of a sad news in the COVID front. So we took this opportunity to meet the public, long-standing initiative from the IMA Tambaram. It was a special live program where the senior doctors of IMA Tambaram took questions from the public, and the 6 panel members from outside IMA, these NGOs, social activists, and a news reader co-hosted and coordinated this program. So this program was supposed to be for 1 hour, but due to the interesting interaction, went on for almost 2.5 hours. So this was a nice initiative where we got into the what people think and what their representatives think about healthcare and also the healthcare facilities in Tambaram area. Thank all the participants from IMA side, Captain GR, who was the initiative for this program, Dr. Balu sir, Dr. Ravishankar sir, Dr. Muthukumar sir again, Dr. Kasi, and all the office bearers for helping us with this program. The State Council meet took place on 1st November. Many initiatives were taken, particularly with reference to the solatium for the private doctors from the government side. So the National President and National Secretary took part in the State Council meeting, and all our State Council members also participated in this meeting. Homage was paid to all the 66 doctors of IMA Tamil Nadu State Board who lost their lives due to COVID. Yesterday, myself and Secretary Dr. Saranakumar met the Joint Director of Health Services to discuss about the solution for our 2 of our members, as well as about the long pending demand of Clinical Establishment Act certificate. In 2018 September, we submitted the application form, but only few got the certificates. We discussed with the JD and the nodal officer. They said many hospitals and clinics are yet to submit the documents necessary for processing the CEA certificate. So with a lot of communication and taking up to the higher official, we got her to sign 63 certificates for the clinics and hospitals, and she formally handed over the certificates to me. But also pending that, we have to give the certificates, the supportive documents, to the Joint Director Office. So these certificates will be issued by the JD officials tomorrow afternoon at IMA building. So the concerned members whose certificates are ready have been intimated by IMA office. So I request those members to come with the certificates and documents which are necessary, which are needed to be submitted to the JD office, and collect the clinical establishment certificate. So remember, tomorrow afternoon between 2 to 3 p.m. We'll be there along with the JD office people. So they will get the documents and hand over the certificates to the concerned medical officer. So ensure that you are represented, the hospital is represented by the IMA member. Another work we are doing along with the government is collecting the data for the COVID vaccine. The government of India has given the first priority to healthcare workers. Government hospitals have their own data, but they want the data from us about the private healthcare facilities. So this private healthcare facilities, IMA has joined hands with the government of Tamil Nadu, and these are the healthcare facilities who will be eligible: private college and hospitals, private hospitals, nursing homes, polyclinics, single doctor clinics, daycare OPDs, laboratories, as well as NGO healthcare facilities. So there are a lot of questions in the WhatsApp group about who are all eligible. So these are the group that would be eligible. So if you have these kind of healthcare facilities, and all healthcare workers will be covered in this vaccine. So all category of healthcare workers, including permanent, contractual, and outsourced workers, are eligible. So please submit the the data in the format they have given. Kindly mail the details to NHM Nodal Officer KPM at gmail.com with a copy to our email ID imatambram1980 at gmail.com. This is necessary. The last 2 weeks we've been requesting the healthcare facilities and our members. So please ensure that we submit this document early to help the government. As discussed in the last meeting also, we formed the crisis management team to help our practitioners during crisis. And so we also did a training program for all the paramedical medical people in our hospitals. Need the feedback and update on this crisis committee. So may I request the other members to please mute your audio. Thank you. We also formed 4 WhatsApp groups under the leadership of joint secretaries to help with the communication and reaching out to doctors during crisis. So please ensure that you are in one of the WhatsApp group as per your area. So we have divided this into 4 groups: East, West, South, and North, and one joint secretary is in charge of this group. So you can get to meet this joint secretary once in a while, as well as know your fellow practitioner in your area. So this is the overview of IMA Tambaram Crisis Management Team, headed by the branch president, secretary, and treasurer, and also with 3 advisors, and NHB wing represented by the chairman, secretary. And these are the joint secretaries for each area: Dr. Gunashekaran representing North, Dr. Einstein in charge of East, Dr. Joseph Xavier in charge of South, and Dr. Saktesh in charge of West. I also happy to wish all the members who are celebrating their birthdays in November. So happy birthday on behalf of IMA Tambaram. And this is the initiative we started 4 months back to augment the resources of our branch, because of the COVID, we have no resources to support our IMA office and all the expenses which are being incurred for the activities. And Dr. Raghavelu sir initiated with his contribution, followed by myself, Dr. Umayal, and Dr. Pandian, and Dr. Rukmani Mohan Kumar. So I request the members who are celebrating a function in their family or birthday to take this opportunity to support our local branch. And as told earlier, imatambaram.in is our website. So kindly update your database so that the communication reaches to you, both your mobile number and email ID in this member directory. That will help us to reach out to you in a better way. We also have a understanding with the Institute of Medicine and Law for the certificate course in medicine. So this is an online course, and they have offered to give a discount to our IMA Tambaram members who are interested in pursuing this certificate course. So this is the link. If you are interested in doing this program, you can contact us, either myself, or it also has a link with our IMA website. So with this information and word of welcome, I welcome you for this November CME. So hope the COVID season goes off with the first wave and without any impact on the second or third wave. Let's stay together, stay positive, and hope this too will pass. And let us go on to the secretary report. I request our secretary, Dr. Sarvana Kumar, to give the report. Kumar, you can share your screen.
Previous report for October 2020. Am I audible, sir? Am I audible?
Yes, yes, Kumar, go ahead.
No, screen teluguda. Are you seeing the screen?
Yes, your screen is visible. You are audible.
Yes, sir.
Kindly come closer to your mic.
Yes, sir. Thank you. On October 10th, 2020, we conducted a Brigade Mariamal Endowment Revolution in Pediatrics. Operation was delivered by Dr. P. Ramachandran, Director of ICT Ignore. And there was also panel discussion on practical tips in pediatric practice with Dr. Kasi as moderator. The participants were Dr. Ravi Kumar, Dr. Saraswati, Dr. Shivakumar, and Dr. A.P. Kritika, our pediatricians of the IMA Tambaram. And on October 31st, we had an online program where the representatives of people's leaders and from Lions Club, Rotary Club, and social activists and NGOs participated in a live discussion with our senior doctors and clarified their doubts. It was an effort to bridge between the doctors and patients and to instill confidence in the minds of the public and to remove misconceptions of them about the doctors. Happy to say that we have a collection of until till date of 5,27,000. We announced 10 days to help the families, support the families of one doctor who died of corona COVID and one doctor serious and sick and still he's under treatment. Recently got discharged. Supporting our demand of approximately 73 of our members are enough to contribute. It shows their bonding and belongingness. I thank all the doctors who have contributed. And last month we classified the WhatsApp group into north, east, south, and west. This is done to percolation of information as well as to make the communication easy for our members. And as our President has already mentioned, yesterday myself and President met at Kanjipuram. Certificates were handed over. Tomorrow, in 2 p.m. to 4 p.m., handed over to the members in our IMA building. One more request in our JD is she has requested all the members who are coming to collect the CA certificate to submit a list of people who need vaccine in their hospitals. So far, we have received only 50 members. They have submitted the list of vaccinations. Members who receive vaccines. We have approximately 450 to 500 members in our IMA Tambaram. So, in particular, that those members who are submitting the vaccination, they PA certificate. Please bring the completed list. Those who have not submitted so far, please submit. Thank you, sir. Thank you for the opportunity, sir.
Thank you, Saranakumar, for the report. So we'll move on to the academic program. So I invite Dr. S. Muthukumar, Chairman, Parvati Hospital, to take over and moderate this session and also introduce the speakers. Over to you, Muthukumar, sir. Sir, Muthukumar, sir.
Sorry. Am I audible now, sir?
Yes, sir.
Yeah. Yeah, thanks to the President. Thanks to IMA Tambaram. I thank the President, Secretary, and the Treasurer for giving this opportunity for us to be a part of this CME program. Let me introduce the speaker of the first topic. The first topic being the importance of flag signs in the management of back and neck pains. Dr. Vinod Kumar is a consultant orthopedic spine surgeon in the Parvati Orthopedic Hospital. He has done his MBBS in Tanjavur Medical College. He did his MBBS in the year 1997, and he did his MS Ortho from Seth GS Medical College and King Edward Memorial Hospital in the year 2007 and 10. He underwent special training as a postdoctoral fellowship in the spine surgery from the Ganga Hospital, Coimbatore. He is a life member of TNOA and IOA. And he is a senior consultant in our hospital, in Parvati Hospital. Add one or two more words about him. A very rare species of a spine surgeon who tries to be very, very conservative. He's a very conservative spine surgeon, and I would say indirectly is a result-oriented spine surgeon. Over to you, Dr. T.K. Vinod Kumar.
Thank you, sir. Good afternoon, everybody. I am Dr. Vinod Kumar. I am a consultant spine surgeon in Parvati Hospital. So am I audible and is my screen visible, sir?
Yes, sir.
You are audible.
You are audible. Your screen is shared, sir.
Okay, sir. Today my topic of discussion would be the importance of the flag signs in the management of the neck and back pain patients. As we all know, the only illness that is occurring more frequently than a low back pain is a common cold. And about 75% to 85% of all individuals will experience a low back pain at some point of their lifetime. So a proper examination and management of these back pain patients is very important. About 90% of the back pain patients are benign. So benign means a short course of rest and analgesics would be enough for the treatment of these patients. But 10% of cases will require a further evaluation, a specialist consultation, and possibly an urgent surgery. So identifying these 10% of patients earlier will avoid unpleasant surprises from the patients. And patients will also be benefited from the early identification of these cases. So for this early identification, the flag signs were introduced in the management of the spine patients. Initially, the flag signs were originally used by the military and this intelligence people to denote the presence of a danger and presence of war available. So there are four flag signs available in the spine. That is, one is a red flags, the other is a yellow flag, and another is an orange flag, and other is a black flags. Here I would like to emphasize the importance of having a checklist while having an examination. So I would like to share in data. There is in the aviation industry, it is said that number of people who lose their life in an aircraft accident is less than the number of people who lose their life doing a bullfighting sports, like a jallikattu in our state. Like in whole world, the number of people who lose their life in aircraft accident is less than these people.
And the number one reason for achievement of such kind of safety in an aviation industry is attributed to the checklist, having a checklist. The other thing like an pilot training and having a better technology, having autopilot technology, or the other things. But the first thing they have attributed is the presence of a checklist, having a checklist in each and every stage of the flight, from the flight start and the flight landing, even pre-flight checkup. They have a proper checklist for everything. And the number one thing that has been attributed to the safety of the aviation industry is a checklist. I would say that having a proper checklist in examination of a patient, especially the spine patients, will avoid an unpleasant surprises from the patients. So first we will start with the red flag symptoms. So these red flag symptoms were introduced to identify a fracture, a presence of a fracture, a tumor, or an infection, or inflammatory disease, or a cardiac syndrome. Cardiac syndrome is where there is a compression of the multiple lumbosacral roots, and there's a dysfunction of the bladder bowel function of the patient, and along with the weakness of the legs. So these kind of patients with red flag symptoms will require an urgent medical evaluation and possibly an urgent surgery also. So first thing I would like to say is the severity of the patient pain is not on red flag sign. So some of the beginners may think the patient is complaining of severe back pain. Some patient will be waking up the whole hospital. So such kind of patient there is high probability of in pathology inside. But actually, it's a reverse. Patient with severe back pain who is not able to move may have been having a less chance of having a pathology than a patient who is walking and complaining you about a mild discomfort in the back. So any pain that is lasting more than 4 weeks, so needs to be evaluated even when there is no red flag symptoms or symptoms. These patients have a higher probability of having a pathology inside the spine. So these patients has to be evaluated radiologically and hematologically. Coming to the age-wise, patient in extremes of age, like patient with less than 15 years and the age patients more than 70 years, the probability of having a pathology inside, some serious pathology like a tumor or an infection or a fracture, is more when the patient's ages are in their extremes. Because in the middle-aged people, the most common cause of the back pain will be a disc degeneration. But in the younger people and the older people, the cause is not disc is not the most common reason. Some other pathology can be there. So some history can be obvious, like a history of fall. When the patient is giving a history of fall, the fracture has to be ruled out by proper radiological evaluation. But some patients may have a spinal fracture even without a history of fall, like a patient with the age more than 60 years with severe osteoporosis, or a patient with a female patient who are undergone a early menopause, either naturally or through undergoing a hysterectomy surgery, and a patient who is on a chronic steroid use or a patient on a poor diet, they may sustain a spinal fracture with a trivial injury, or even without an injury, they may have a spinal fracture. So these kind of patients, when they give a this history, this especially the chronic steroid usage and female patient who has undergone hysterectomy, these patients has to be evaluated to rule out the presence of a spinal fracture. So then again, the quality of the pain, some patient may give a history of usually the back pain due to disc degeneration would be an dull aching or throbbing pain. So when the patient give a history of a burning type sensation over the back, and a burning pain over the neck and the back, these patients have high probability of having some tumor inside the spine or spinal cord. So any patient with a burning pain has to be evaluated earlier, and especially the patient with the intermittent pain. Sometimes, usually the patient with the renal colic will be having a pain over the flanks, but some patient with the renal colic may present with the centralized pain, which will be intermittent in nature. So they may be associated with having a hydronephrosis also. So these kind of patients has to be identified earlier, especially when the patient is giving intermittent pain. At some point, the patient will be having unbearable pain, and some point it will be absolutely painless. So such patient, if we keep on pumping painkillers in this patient, then there is high probability this patient will end up in renal failure, because there already the kidney function will be compromised due to the hydronephrosis. And the presence of a wrist pain or a night pain, especially the patient complaining, the patient being awakened in the middle of the night by the pain, it suggests that there is some inflammation or a bony distraction going on inside. Because during the daytime, the spasm of the muscles will keep the inflamed bone away from each other, and when the patient lies down, due to the muscle relaxation, the inflamed bone will rub against each other and will start producing pain in the middle of the night. Such kind of night pain and rest pain needs to be evaluated at the earliest. And especially the surgery history, that some patients may have undergone a surgery 5 years or 10 years back for a cancer, like a breast cancer, the patient may have undergone, and the treating surgeon would have said that your cancer has been cured, but the patient may not find it relevant to say this history to you unless they have specifically asked. But after 5 years or 10 years down the line, the spinal metastasis may be the first sign of a tumor recurrence. So the history of this sign of surgery has to be specifically sought for. And especially the patient undergoing thyroidectomy. So patient may be undergoing thyroidectomy for hyperthyroidism. So these patients, what they will do is they will be removing the parathyroid gland also along with the thyroid gland. So these patients will be having a low hypocalcemia and probably a weak bone, osteoporosis. This patient has to be evaluated and proper calcium supplementation has to be given. So, any patients presenting with bladder and bowel disturbances, especially our Indian females will be very reluctant to say this history of having an urinary or bladder disturbances. So this history has to be specifically sought. Any patient that a urinary retention or a hesitancy, patient having incontinence of the urine, or a patient having urgency, and perianal presence of a perianal numbness, and these patients suggestive of a cauda equina syndrome. Patient having this means the patient is having a compression of the lumbosacral nerve roots, and this is one of the orthopedic emergency. These patients has to be operated within 6 hours so that the function of the lumbosacral roots will recover faster. So there are, if you unnecessarily delayed, the chance of recovery of these patients will not guaranteed. And the presence of progressive weakness of the legs and the upper limb. So these also suggest increasing compression. It could be the compression either can be due to the disc or some tumors tissues. So any patient presenting with a progressive numbness and weakness has to be evaluated on an urgent basis. And the presence of morning stiffness, especially the patient says when they get up in the morning, they feel severe pain and they have to difficult in getting up from the bed and involved in day-to-day activities. So morning stiffness is a sign of presence of inflammation, and the inflammation can be either due to presence of an infection or any rheumatological issues. So this patient has to be evaluated and treated accordingly. And finally, presence of constitutional symptoms like fever, loss of weight, or loss of appetite is a sign of infections going on inside. But the present scenario, the availability of better nutrition right now, about 50% of the patient with the tuberculosis won't have any symptoms right now. So in my clinical practice, I have seen almost 50% of the patient with tuberculosis will not be having any fever or loss of weight or loss of appetite. With any patient presenting with fever and weight loss, it has to be evaluated. So next, coming to the yellow flags patient symptoms are especially given to the patient, especially with occupational causes. So the patient's occupation may be producing him the back pain, and identifying the cause and just giving him proper advice to correction of these occupation will not just providing him with painkillers. Patient will be coming again with persistent back pain. So first line of management of this patient would be a lifestyle modification, especially patient who is doing an IT job where he has to sit continuously. And in the present scenario, the most of the IT employees are been doing in work from home situation. So work from home, what they in the office, they will be having a proper work desk and proper ergonomic chairs and tables. But most of the people working from home will be just working, sitting in the bed or couch, or even somebody will be working, sitting in the floor. These kind of patients will be having higher incidence of a back pain and disc issues. So patient who job requires repeated weightlifting and driving, especially taxi drivers who have to drive a long distance. And due to the non-availability of public transport system in this corona situation, these patient will be most of the patient will be traveling to the working place in the two-wheelers. So the repeated they will be traveling around 50 to 100 kilometers per day. The repeated vibration in the spine will cause an accelerated degeneration of the spine, and they may causing pain in these patients. And some patients may have to undergo repeated bending activities, like people who are doing a frisking activities in the airport. These people will be having a higher incidence of a disc degeneration. These patients, apart from these routine painkillers and rest, these patients has to be advised against a proper posture, and a proper posture while sitting, and proper posture in weightlifting, and has to be advised against driving two-wheelers or car for a prolonged period of time continuously. And coming to the orange flags, these orange flags are due to the psychological issues that is causing back pain and neck pain. And these patients will require a proper psychological or psychiatric counseling treatment for their cure. Otherwise, just painkillers won't work in these patients. Especially the patient any patient having a pre-existing psychiatric illness, they tend to exacerbate the symptoms. They won't get cured of the back pain with a routine treatment, and the proper treatment of the psychiatric illness from the psychiatrist will help in the treatment of these patients. And some patients who are having a psychological issue can be precipitated as a back pain or neck pain, especially when the patient is having teenage issues or intermarital issues, or old age isolation patient who stays in isolated during their old age period. These patients will have, and psychologically the back pain will be exacerbated. But I feel that most of the general practitioners are better in counseling the patients than a psychologist. So a proper counseling from a psychologist or a general practitioner is required for the treatment of these patients. And coming to the last thing is the black flags. The black flags are especially for a patient, especially a patient who had undergone a workplace injury. So this patient, if you evaluate this patient, everything will be normal, but the patient will be still complaining of an persistent severe pain. And these patients will be compensation minded, and some patient may believe that reverting back to work is harmful, and the chance of re-injury is there. And some people will have a poor job satisfaction, and the poor colleague supervisor relationship. These kind of patients will be compensation minded, or they want to extend the leave, and it's better to avoid any intervention in this kind of patient. And especially patient blaming the other doctors for their pain. Especially the patient may say that because the pain they are having is due to some spinal anesthesia given by a doctor years ago, or somebody say that due to the physiotherapy given by a doctor some years ago, he started having the back pain. So this kind of patient is most probably is going to go to the other doctor and going to blame about you. So it's better to treat this, avoid treating such kind of patient, or better refer to a doctor surgeon whom you don't like it. So coming to the end, the take-home message will be that we should having a proper checklist for these flag symptoms, especially patient evaluating a patient with a spine problem. There should be a proper checklist in evaluating the patient. So if some no symptoms are unnecessarily left, and you end up with an unpleasant surprises. So all the patients should be evaluated properly. And second thing is, you should pay most of the time when you see the patient will try to push in the MRI reports and the files that are seen by the previous doctor as the first thing to you. So never try to look at these images or files, because you will be misinterpreted by the diagnosis made by the previous surgeon, or MRI findings, because the MRI they would have represented as reported as a mild disc bulge, L4 L5 disc bulge, but the cause of pain will be completely something else. So first thing we have to do is a complete the elaborate history taking and detailed examination of the patient. Then only you make a mental diagnosis and then correlate your findings with the radiological findings available with the patient. So this kind of wrong diagnosis, and you are not influenced by the diagnosis made by a radiologist or any previous doctor who has treated the patient. And you have to be beware of the false positive and false negative, so this flag sign symptoms, because some patients may not be having any of these flag signs but still having some serious issues, or some patients may having these red flags, and if you evaluate it, everything will be normal. So you have to have a clinical judgment and radiological finding. And any patient with more than 4 weeks of back pain needs to be evaluated properly. Thank you very much.
Thank you, Dr. Vinod Kumar.
Yes, sir. Thank you.
It was a very elaborate and very, very good session. And it is very, and you have kept yourself very clean, that the information would help the general practitioners.
Yes,
The floor is open for discussion now. Any questions?
Dr. Muthu, SMK, or I got a question.
Yes,
Can I ask?
please.
Somebody, my sister is having a long-standing cord compression, disc prolapse and some neural compression. But she's able to walk and do her routine things without any much of bending or straight sitting. But she's uncomfortable only in the night because of pain and numbness in the leg, but which is not constant. What can we do it for the disc prolapse? They said it's a grade 3 or something, but no other symptoms.
Okay.
Can we leave her or can she undergo surgery?
Vinod, you can take the question.
Yes, definitely. Thank you, sir. Madam, as I have told you, the treatment of disc problem is mostly a clinical radiological correlation. The first thing has to be the patient has to be properly evaluated, and see what are our lifestyle activities that has to be changed so that she will have a better pain relief. So surgery will be the last option for a patient with a disc prolapse, even after all the conservative management has failed. Only we will be considering about surgery. The first thing would be the treatment by lifestyle modification. We have to, with proper detailed history, we need to find out what is what the bad lifestyle she is having, and that has to be changed. And she has to be put up on a proper physiotherapy exercise program. With the proper lifestyle modification and physiotherapy exercise program, about 60 to 70% of the patients will be cured of their back pain, and the quality of life will increase. So another 30%, some patients would benefited from getting an epidural steroid injection, just putting a steroid injection nearby the root that is getting compressed. And if a patient is not responding to any of the treatment like lifestyle modification exercises, tablets, and the steroid injections, everything, then we can consider about surgery. If provided if the patient is not having any neurodeficit at present, like a presence of weakness in the legs or a bladder bowel disturbances is not there, then we can put her on a trial of conservative management. And if it is not working, then we can consider about surgery.
Thank you so much. Thank you.
Okay. I would like to emphasize the importance of the history taking again, because it could be the history of knowing about the morning stiffness, or about the thyroidectomy they underwent, or a cough muscle pain the patient has. The history taking plays a very major role. Most of the time has to be spent in the history taking, and that will lead your way to do the clinical examination. And the standard pattern of clinical examination for the general practitioners, probably I would say, the very simple clinical test. To say, Dr. Vinod was talking about madam also was talking about neurological deficit. As Vinod was saying, the proper examination, in spite of saying so much about the neurological deficit, it gets missed out so easily. We always think we need to see a great deficit. All the time we find that there is nothing, but when you make the patient do walk on the heel or walk on the toe, then easily find out that if they are having difficulty in walking on the heel, then it's L5 weakness. When they cannot walk on the toes well, if they keep stepping down, then it is S1. Same way, another important thing is seeing them just bend the spine and touch the toes. The amount of flexion will also give a very good idea. And also the spinal rotation. Very simple way to do the spinal rotation is examination for SLR when we do supine, and then make them go into prone. When they turn from supine to prone, that's the time we can easily see the spinal rotation. These are the very simple tips which completes your spine and probably the neck examination as well.
Thank you. Thank you.
Thank you.
Question, Dr. Vinod Kumar.
Yes, sir.
Do you prefer epidural steroids or root block?
Sir, I prefer an epidural. I prefer a root block more than an epidural steroid, sir, because epidural steroid is usually given in the posterior epidural space, where most of the cause of pain will be in the anterior, like a disc compression or a root compression. The pain generator will be in the anteriorly. So I prefer an transforaminal selective nerve root block for a pain relief.
Right, sir. Thank you. Thank you, sir.
Who will give the root block? Doctors or the anesthetist?
Sir, I will even find surgeon, anesthetist, anybody who has trained in pain medicine, sir. The pain medicine. So the pain medicine will be open for both the anesthetist and the orthopedics. Whoever got a training in can do it.
Vinod is a pain analyst. He also has his special techniques of
I've been trained
channel blocking techniques for pain relief also.
So I have undergone a fellowship training in an interventional pain management. So I'm well versed in training this, doing this transforaminal root blocks.
There are no more questions. Shall we move on to the next topic?
Yes, sir. Yes,
yeah,
sir.
Thank you, sir. Dr. Naresh Kumar will talk about osteoporosis. He's a consultant orthopedic surgeon in Parvati Hospital. He did his MBBS in Stanley Medical College and MS Ortho in the Municipal Medical College, Ahmedabad. He did his fellowship in minimal invasive orthopedic trauma surgeries in National University of Singapore in the year 2011-12. He also did his traveling fellowship in Ganga Hospital, Ortho One Hospital, Mukhopadhyay Ortho Center. His specialty interest in he's specially interested in complex orthopedic trauma, post-traumatic limb lengthening, reconstructive surgery, orthopedic oncology. He's a life member of IOA, TNOA, and the AVO group also. To talk a few more words about Dr. Naresh, we have asked him to list his interests, so he gave few of them. But I have always seen him getting interested into everything. But he is specialized in non-union. In our hospital, he is called as a non-union specialist. He's very good in handling the non-union cases, and is also a very good upper limb trauma surgeon. Over to you, Dr. Naresh, for talking about osteoporosis.
Thank you, sir. Thank you for the warm welcome. Thank you, President and other office bearers and all the members. So is my screen visible and my voice audible?
Yes, sir. Yes. Screen is visible. You are audible, sir.
So the topic is on management of osteoporosis in 2020. So maybe around 8 to 10 years ago, whenever there was when I had to sit through a talk on osteoporosis as an audience, I couldn't control my sleep. So it's generally considered as a very not so exciting topic. But after I entered into orthopedic practice over the last 8 to 10 years, my perspective about osteoporosis has changed significantly. So this presentation is a compilation of what I have learned through all these years, and I hope this throws some light into the newer aspects of treatment and the methods of treatment. So osteoporosis is the most common metabolic bone disease. So we are all familiar with this definition. We have seen this definition several times. But unfortunately, most of us, when it comes to bone, we always think only about calcium. But we should realize that the bone is only 60% of calcium. The rest 40% is a protein matrix, which provides the structural integrity to the bone. The calcium and other minerals like magnesium, strontium, they contribute to the bone mass, but the structural architecture is provided by the bone matrix. So we should keep this in mind while treating osteoporosis. Unfortunately, osteoporosis has not enjoyed the same popularity as other non-communicable diseases like hypercholesterolemia, type 2 diabetes, essential hypertension, other malignancies like CA breast and prostate or cervical cancer, in part because it's a silent disease. So most of the times the patient comes to us and we find that the patient is osteoporotic only when she has actually fractured her bone. So that contributes to gross underreporting as well as underestimating of the disease. But the Western population, they have done a lot of spade work on understanding the gravity of the situation. They have formed several societies and foundations to have a registry of the incidence and prevalence of osteoporosis and osteoporosis related fractures and bone diseases. But somehow in India, we are yet to form a proper body to monitor the prevalence of osteoporosis. There are, of course, some societies, Orthopedic Osteoporosis Society of India and Indian Society for Bone and Mineral Research, but still we don't have proper reporting. So that in that way, we cannot really say, comment on the prevalence of osteoporosis in India. But there was a study done by International Osteoporosis Foundation, and it was submitted to WHO. It's found that among females more than 50 years of age, 1 out of 2, that is 50% of the females above 50 years of age will suffer from osteoporosis. But unfortunately, the complications of osteoporosis are much more severe in our population, and the severity of osteoporosis is also much more in our population compared to the Western population, in part because of our nutritional habits and lack of exercises compared to the Western population, genetic predisposition, and our body frame is generally thin compared to the Australasians and European and Western populations, and other lifestyle issues. So it is estimated that by 2050, almost 50% of all the osteoporotic hip fractures will occur in India and China, and India will likely become the osteoporotic capital of the world. So the real problem begins here. So we might consider previously, even honestly speaking, even me, when during my UG days or during my early PG days, I used to consider osteoporosis as something like a graying of hair or wrinkling of skin, something related to just brush it aside like some chronic condition of old age. But actually the problem begins when the patient fractures her hip. So in this discussion, we will consider postmenopausal we'll give more importance to postmenopausal osteoporosis, and other forms of osteoporosis are less common. So this is a patient, when she presented here, most of the times this is a scenario which we see. This is the first time the patient, neither does the patient nor does the doctor know that the patient was osteoporotic unless she came to us with this fracture. Only when after this fracture we realize that the patient is actually osteoporotic. So now the problem is, if this patient had been diagnosed with osteoporosis, say about 20 years ago, we could have treated her and probably avoided this fracture. This fracture alone is not a major issue. The problem is how are you going to make her walk again? I have had a bad experience in my own family. My grandfather's brother, that was a time when I was doing my post graduation. He's from a village. He sustained a hip fracture and somehow they did not get him operated. He used to be active riding bicycle, but after the fracture, he started isolating himself. He thought that he is going to become a burden for others. He stopped eating, and finally he expired actually. So this is just to re-emphasize that osteoporosis is not a very it's not a very light thing to take. It has got grave consequences. It can actually kill a person. And not to forget the amount of economic impact a hip fracture has, and osteoporosis on the whole has. So on an average, all over the world, there is a paucity of proper data, but rough estimates say that to treat osteoporotic hip fracture, it costs about $5,000. That's about 3.5 to 4 lakhs. And on an average, there are about more than 20 lakh hip fractures occurring every year around the world. So that means that just to treat hip fractures alone, the cost is 74,000 crores. This is in fact an underestimation. The actual value should be much more than this. And not to forget the risk of mortality, the economic losses due to job loss, permanent disabilities. It is said that a patient, if 100 patients get a hip fracture, 25 among them might probably die within the next year or two. And another 25% will sustain another osteoporotic fracture in the next 2 years. Right. So the scope of this presentation is mainly to evaluate how do we actually evaluate the bone health of a patient, whether what we are doing is presently is correct, and is our prescriptions scientific and correct and evidence based, and what next can be done, what is the way forward. So there are some markings on my screen. I don't know. Anyway. So I just have a small incident to share.
Please go ahead, doctor. Somebody is doing some annotations. I'll try to cancel it.
Fine, sir.
You carry on.
Right. So when I was doing my internship house agency in Stanley Medical College, during my internal medicine posting, the first year medicine PG used to during on our OP days, they used to come to the OP, ask the MNA to separate the table from the main table and make a separate pathway, barricading with the benches, and ask the MNA to segregate a group of people outside the OP itself. And they used to ask the house surgeon to sit in that table, and the instruction was to clearly dispose of all these Kaikal Kodachal cases. So that used to be a common scene. Of course, I'm sure it must be there in all medical colleges. So that was the kind of attitude that we had when we see patients with generalized body pain. So what we used to do is we used to actually write down about 50 to 100 slips of paracetamol 500 milligram, calcium 500 milligram, and B complex tablets. Keep it with us. The moment the patient comes and starts saying, even before starting to say her complaint, that is, she's developing pain from shoulder to back to knee. Before even listening to her, we used to give her that slip and go and get the medicines. So that was how I feel really guilty for having been irresponsible. But that's how it has been. In general, how we prescribe is when a patient with osteoporosis. In this case, we will consider a sample patient of 50 years old, a female. So when she comes with generalized body pain, So what we generally do is we straight away we label her as osteoporosis related pain, and we give her vague advices. For example, take plenty of milk, do a lot of exercises, and then take calcium rich food, take protein rich food, and then we start prescribing calcium tablets, or some of us start prescribing uh, bone anti-resorptive agents like alendronate, and we give vitamin D injections rampantly. So the aim of this presentation is, are we rational in our prescriptions? So that is the whole motive of this presentation. So let us again go back to our patient, 60-year-old female. So we know that her calcium requirement per day is 1,200 milligrams. And we make a small calculation based on her dietary habits. So there is a simple formula given to roughly estimate the amount of calcium consumed by each of us every day. So the main sources of calcium: milk, curd, cheese, fruit juices, vegetables. So on an average, this one glass is actually the bigger glass. Our tumblers are maybe must be about 75 ml to 100 ml. So we should take all these things into consideration. Also, we generally have the habit of using ghee or butter, but they don't contain calcium. They are actually saturated fats only, and it doesn't contain calcium. It should be cheese. So for our patient, if we put a rough calculation, say she consumes 2 glasses of milk, 1 cup of curd, doesn't take cheese, one maybe orange juice or something every day, some vegetables. Even after all this, her daily intake will be 980 milligrams. But I can vouch for sure this will not be a dietary habit every day. This will be definitely half. So estimates suggest that our daily calcium intake is less than 500 milligrams every day. So in that case, we can find what is calcium deficit every day. So that is 1,200 milligrams minus whatever she takes. Say, let us assume that she takes 750 milligrams of calcium every day. So that is the deficit. So that means 450 milligrams of calcium deficit every day. If she has been having this dietary habit for the last 20 years, that means we can calculate, can just see how much will be the amount of calcium she hasn't taken for the last 20 years. So it is very pertinent that we make a rough calculation of her dietary habit before jumping into prescribing her medications. Of course, there is a recent renewed interest in health supplements, mainly because of a lot of nutraceutical companies, and and also because of people getting information over the internet. So most of us, when we go to a supermarket, or we have the habit of asking what is the latest which is available. So there is no latest in calcium. It is all our age-old. Our forefathers knew what should be taken. So whatever is available locally, we need not go for exotic cereals like muesli or quinoa and things like that. So just our usual millets. For example, the richest source of calcium is our ragi, which we use commonly. So 100 grams gives 300 milligrams of calcium. So we can also these resources. That is, if we are really keen to calculate how much we consume every day, we have a lot of information over the internet to calculate the amount of calcium present in each food. We should also not forget that just the nutritional intake alone is not it doesn't complete the picture. So how are we losing calcium every day? So for example, we all know this already, caffeine, high sodium diets, and taking high intake of phytates and oxalates. We use tomatoes left and right in all the preparations. So that contains high amount of oxalic acid, which will bind calcium in the stomach itself and prevent its absorption. And habit of having carbonated drinks, then cocoa products, all these will either prevent absorption of calcium from the gut, or it will leach calcium from the bone. So next, so we have just made a rough evaluation of our patient. Now we are tempted to prescribe her some calcium supplements because her daily calcium intake is very low. So there are innumerous brands of calcium. The list is endless, and but there is a lot of marketing in this. But we should be prudent in how we prescribe. So whatever said and done, calcium tablets, they just either calcium carbonate or calcium citrate. So these are the most the recommended forms of calcium, and which have got highest bioavailability. Other forms of calcium like lactate, phosphate, gluconate, they all have low bioavailability. Also, other commercially available supplements like oyster shell, coral calcium, they are all not recommended. Of late, there is for the last few years, there is a lot of news about coral calcium, but it's just again calcium carbonate only, so which we can prescribe from a cheaper brand. So now, how to choose between carbonate and citrate? So carbonate has got the highest bioavailability of 40% elemental calcium. Citrate has got 20%, but the problem with carbonate is, though it has got a higher percentage of calcium, it is not so well tolerated by old age people, mainly because of its gastric side effects like constipation. Whereas citrate is well tolerated, but the amount of calcium in it is less when compared to carbonate. So we need to make a choice between either calcium citrate and calcium carbonate. Also, we need to make sure that whatever brands are available, the numbers mentioned in it is actually the elemental calcium. So for example, we have a calcium citrate tablet, some brand of 500 milligrams. And the calcium citrate, for example, we prescribe 500 milligrams of calcium citrate. The actual elemental calcium that goes into the patient is only 100 milligrams. So we need to keep this in mind while we prescribe. So most of the patients, this we encounter very commonly. When we talk about calcium, the next thing they ask is, I had some renal stone some years ago, can I take calcium? Or if I take calcium, will I get a renal stone? Actually, the renal stones are not calcium stones. They are either oxalic acid stones, uric acid stones, and calcium is actually one, it just makes it as a salt, but the actual crystal is oxalic acid most commonly. So, calcium intake has not been associated with renal stones. On the contrary, if we take calcium, it will actually bind the oxalic acid and prevent the oxalic acid levels to rise in the serum. So it is protective. Also, calcium citrate, the citric acid helps to excrete oxalic acid, so it will prevent renal stones. But of course, if a patient has already had a history of renal stones, we need to be a little cautious in giving calcium supplements, especially we shouldn't try to overdo it. But there are some studies which show that heavy calcium supplement intake has been associated with pigmented gallstones. But by and large, there is no direct association between renal stones and calcium intake. Next, so having done with profiling her calcium intake, now if we want to see how much vitamin D she is taking. So the recommended daily allowance is about 800 to 1000 international units per day. So again, but the problem with vitamin D is it is difficult to calculate how much a person consumes vitamin D every day, because the amount present in the dietary sources is less, and most of the source of vitamin D is through the sunlight. So it is difficult to quantify it. Again, the same formula applies. the recommended daily requirement minus the person's dietary intake is the amount that has to be taken as a supplement. So just a brief refreshment about vitamin D. So the cholesterol which is present in our skin gets oxidized to vitamin D2 as dehydrocholesterol. Dehydrocholesterol is an unstable form of cholesterol. It gets quickly hydroxylated in liver and kidney to form subsequent stable forms of vitamin D. That is vitamin D3. So when we talk about sunlight and vitamin D, most of us as well as our patients think that we live in India, and so naturally we get a lot of sunlight, and we move around in our two-wheelers or we walk in the sun. So we cannot be vitamin D deficient. So many patients they refuse to accept that they are vitamin D deficient. But we have to get our facts clear. So how do we walk? Generally, when it comes to walking in the sun, it is mostly early in the morning or in the evenings, where there is abundant by ultraviolet A light. But what is required is ultraviolet B, which is present in plentiful between 10 a.m. to 3 p.m. So if we have to get vitamin D through sunlight, our exposure should be during this time. Also, most of us, due to our cultural habits, we are fully clothed, and the exposed part of our body is only the face and maybe the forearms and hand. So, to get about 1,000 units of vitamin D every day, at least 15% of the body surface area should be exposed for 40 minutes between 10 a.m. to 3 p.m. It's called midday summer sunlight. So, timing of sunlight, the period of the year during which we do all these things come into play. So, by and large, we shouldn't think that. First of all, we should get rid of the idea that we are in India and we cannot be vitamin D deficient. As such, dark skin and dark skin people are prone for vitamin D deficiency. So, most of our facts are actually wrong. Right. So other good sources of vitamin D are cod liver oil and mushrooms. Cod liver oil, yes, definitely they are beneficial. We can also substitute it with a common fish which is available here. Among the fishes, salmon fish is supposed to have the highest content of vitamin D, but it is not a staple diet in our country. Instead, say if we are non-vegetarian, then we can, instead of buying other varieties of fish, if we are keen, then we can buy this mackerel fish, which is actually very commonly available kelithimine. So that contains about 1,000 units of vitamin D. That is every 100 grams. Coming to mushrooms, they are a rich source of vitamin D, but what usually happens is we buy mushrooms and put them in the fridge immediately and then cook it the same day or the next day. So instead of that, there are studies which show that mushrooms can actually synthesize vitamin D even when they are cut from the plants and then when they are exposed to sunlight. So instead of putting them in the fridge, if we dry them for about 6 hours every day, 6 hours a day for 2 days. I'm sorry for the clerical error. So the amount of vitamin D actually increases to 46,000 international units, which is really staggering. So we can fine-tune our existing practices so that we get the best benefit out of what we eat. Also, when we buy this fortified milk and fortified oil and vitamin D enhanced other foods, we need to check the the daily value of vitamin D which is available in that. So if it is say for example,
Naresh, request you to finish it a little quicker because there is one more session.
Sure, sir.
Yeah.
So then next, we would like to prescribe some exercises for our patient. The exercises are divided mainly into light weight bearing exercises and stability exercises. So there is a lot of interest on this Nordic walking. This is not something very cumbersome. This is in practice in European countries to use two poles. The main aim is to keep the upper back straight and to walk fast. We can actually add resistance by adding a bag to it. So the main problem which we see is as we age, we get this kyphosis. So this type of walking helps in avoiding kyphosis. This is again another slide which shows the effect of low upper back strength in spinal deformity. Next, so we need to know whether we are dealing with either primary osteoporosis or secondary. So most of the times it is primary osteoporosis, and primary osteoporosis is either postmenopausal or senile. So in evaluating the patient, we need to do some baseline blood investigations. In special situations like malignancies and other chronic conditions, genetic factors, metabolic diseases, congenital diseases, we need to consider doing other investigations to find out the root cause of osteoporosis. So then we are going to stratify the risk of the patient. So in general, these are the factors which increase the chances of osteoporosis. Female gender in general, Asian race, thin body frame, excessive alcohol, smoking, poor nutrition, any GI surgeries, early menopause, amenorrhea, and then chronic diseases of the liver and kidney, prolonged immobility, hyperthyroidism, hyperparathyroidism. So we need to take into account all these things before we stratify the patient as to which category of osteoporosis they belong to. Next, another common situation which we encounter is whether BMD test is necessary. BMD is bone mineral density. The technical name is dual energy X-ray absorptiometry, which is a low dose X-ray. Yes, BMD test is definitely needed. It is because with that, we can actually predict the risk of a fracture the patient can develop later on. And it is not so expensive. It is something like we can compare it to a mammogram. So how do we interpret a BMD test? There are two scores, T score and Z score. For our case, in usual practices to quantify postmenopausal and senile osteoporosis, we are concerned about the T score. So if, for example, if the T score is minus 2.5, that means that the patient has lost 25% of her bone mass, which was there when she was at 30 years of age. So the Z score is important when we are evaluating a case of secondary osteoporosis. Say if the patient has got a low T score, then when should we repeat the BMD test? So that is also a common thing which most of the patients ask. So usually if the score is less than 2.5, then it has to be repeated the next year. If it is higher, then it can be repeated maybe 2 years or 5 years. Some studies say that it is enough if we repeat it after 15 years if it is in the normal range. So in UK, they have devised a risk assessment tool, the risk of a fracture risk assessment tool. So it's a very simple formula to calculate the risk of fracture. So in our case, the patient is 60 years old. These are our anthropometric measurements. Her T score is 2.5. So we can immediately get the result that the risk of fracture that she can develop in the next 10 years. So in our case, it is about 10%. So this gives a rough idea about how we are going to manage the patient. So having done with calcium, vitamin D and evaluation, the next step is to treat osteoporosis pharmacologically. We have a few options. either drugs come under the category of anabolic agents or antiresorptives. So usually used anabolics are parathormone injection as subcutaneous injections, strontium granulate tablet powder, nandrolene as injection, and estrogen replacement therapy. Among the anti-resorptives, so we have commonly used bisphosphonates, that is residronate, ibandronate, and zoledronate, and calcitonin nasal spray, and denosumab, which is a monoclonal antibody against the osteoclast receptors. So these have got some specific indications. They are not used in all patients. So finally, what it's expected from us is a combination of all these things in our prescription. But good nutrition, that is, it is not just good nutrition, exactly the amount of what the patient is supposed to take, exactly the amount of exercises the patient has to do, the duration of exposure to sunlight, all these things in a very precise manner. So it becomes more meaningful for the patient, and it is easy to track the patient whether the patient is actually doing carrying out our instructions properly or not. Yes. So this calls in for a holistic approach. The concept of lifestyle medication is very popular in Western and European countries. So we should move on from a stage of just in treating osteoporosis, just as a purely orthopedic hospital, to an orthopedic wellness center, which should include physician, gynecologist, endocrinologist, a dietitian, a good physiotherapist, patient counselor, and all the facilities for investigations. Yes. So thank you all.
Thank you, sir. Thank you, Naresh. Now the floor is open for discussion. It was wonderful, Naresh. Thanks. It was a bit elaborate, but still it was a good one. Thanks for highlighting almost every aspect. The floor is open for discussion. Now the most common topic, I think everyone encounters this, and it's going to become the most prevalent problem in the country. And of the 74,000 crore shares in the entire world, of course, most of the orthopedic hospitals do get a lot of these osteoporotic fractures. Saravana Kumar would agree, Dr. Prestidas, the orthopedic hospitals get to see a lot of these osteoporotic fractures, and it puts the entire family into a big trouble. It's just not only the patient who suffers from pain. The moment there's a fracture hip, the patient becomes bedridden. It's going to become an add-on burden to the entire family. So it's always better to prevent these types of fractures.
Sir, one question.
Yes, sir.
Yes, sir.
Please
Yes,
go ahead.
Tambaram. Okay, I think he is not audible. Is there a genetic component to osteoporotic factor? Does it run in families?
Yes, sir. There is a estrogen receptor gene which has got genetic differences among various population groups. So depending on that, similar to something like CA breast and CA cervix, certain population, they are predisposed to osteoporosis, especially if the parent has also has been had osteoporotic fracture or has been suffering from osteoporosis.
Okay. And the vitamin D prophylaxis, how long you give for these patients? Continuously, or because as an ophthalmologist, I also come across many vitamin D deficiency patients, most of them present with dry eye. So it seems to be a systemic illness manifesting in various specialities and different symptoms. So how long you give this vitamin D? Because we ended up treating a patient with vitamin D of one trade name, and unfortunately she was taking 2 other different forms of vitamin D also.
And that is a usual problem. So generally, I caution the patient before prescribing vitamin D and ask them whether they are prescribed vitamin D anywhere else before starting to prescribe. And it is a good practice to check the vitamin D level before starting. If it is in the insufficiency range, then we can supplement with oral vitamin D and dietary changes. If it's grossly deficient, then it is better to give. The usual practice is giving vitamin D as 6 lakh unit injections, 2 or 3 doses.
How long is the question, sir? How long?
So what I generally do is I recheck the vitamin D level at 6 months, and during that time, for the first 2 months, I give vitamin D as a weekly dose of 60,000 units. After 2 months, it is once a month dose.
Okay, thank you.
In my view, I see multiple parameters. It's just not only vitamin D, also about DEXA, and also about the symptoms. It is normally a very prolonged treatment till we could see cumulative effect. Either the symptom will go away, plus the vitamin D values become at least start improving. That's the time we will think of receding from the supplementations. And it's not that easy. It has to be multi-pronged. They have to start doing, and walking is generally a very good exercise, that early morning walking. So even though when the calcium is taken in, it has to be absorbed, and especially we are talking about orthopedic as a subject. So for the calcium to get absorbed, we need to load the bones. The moment the bones are loaded, while loading exercises like walking, then only there is a negative electricity produced inside the bone. It it allows absorption of the calcium into the bone. So it's multiple parameters.
Yeah, I think that the mushroom point was really interesting, because many of us, even if we use that, tend to really stack it up in the fridge and then
Exactly.
straight away cook it. So if we are
Sun-dried
really
becomes
using,
so powerful.
yeah, okay,
I
thank you.
have a question, sir. Muthukumar sir.
Yes, sir.
I have got a question. Have you seen any patient symptoms improving with treating vitamin D?
Yeah. See, actually, symptoms quite quickly improve with vitamin, especially when you give salmon calcitonin. It also has a placebo effect. They quickly improve, sir, but it has to sustain. So we keep watching them for years. Many of my patients are on follow-up for a very long period. Some of them are even there in follow-up for the last 10 years. So I do not continuously give, and I give a break, and I alternate. Sometimes you also lose follow-up. The follow-up is also another important problem. So I always give them a standing instruction not to continue this, and I ask them to give a break. So I always give them a calendar of 1 year, 2 months medication, 2 months gap, so that if at all they don't come to us also, they are not overdrugged. But they do get symptomatically relieved. Like what Naresh said, that Kaikal Kodachal syndrome, primarily it is because of the soft tissue rheumatism.
Yes.
It is not because of osteoporosis. The second would be probably in that group of big group of soft tissue rheumatism, which is so prevalent, this also gets mixed up.
That's what I also feel, sir.
Yeah,
More like a placebo.
exactly.
Actually, correcting the values. Even after correcting the values, some people getting the pain. We are
No,
not
but
doubt.
the generalized body pain definitely gets become better when you correlate with your BMD and your vitamin D. It's just vitamin D is not a very good parameter. You have to correlate with all that, and also to make the patient take up the habit of exercise. After all this, nothing will work if they don't start doing their exercise. Whatever is possible for them. Even if it's an old senile patient, they have to start doing simple ground exercises. They have to start loading the bones. Only then they become better.
Very well.
Thank you, sir. Thanks to the president again, secretary, and the treasurer for giving this opportunity. Over to you, back to the president and the secretary, sir.
So thank you, Muthukumar sir. But please stay with us, because the next topic also you would be one of the expert people in with reference to health
Yeah, I'm
insurance.
saying that.
So do join the panel to share your experience. So
Sure.
I thank Dr. Naresh Kumar and Dr. Vinod for sharing their experience and expertise with us. Both were excellent talks, and I'm sure the recordings will be seen by many people. And I also request both the speakers to share this in a write-up so that we can send it to all our members through our newsletter. Okay, so kindly share the write-up or even the PPT as PDF. We can circulate it to the members.
Will do,
So
sir.
thank you. I request Dr. Saktesh, our
Sure, I will do that.
yes, thank you. So we'll move on to the panel discussion. Been waiting for a long time, all the three panelists. So once again, welcome Dr. Chandrakumar, Dr. Madhavan, and Dr. Gunashekharan sir for this panel discussion. I request Dr. Saktesh, our Joint Secretary and prolific ENT surgeon, to take over and moderate this session. As you all know, during the COVID time, so many of our doctors fell sick, and some of them succumbed to the infection. But the families went through a very horrible time because the cost of treating a COVID infection and supporting them after the infection was quite huge. Since the protocols were not well defined and many of us had comorbidities, the cost of um, sorry, the cost of care was really huge. So that is the added burden to the families and the care providers. And that is the time when many of us felt about some form of insurance. So whether even if we have some insurance covered, that was not adequate. And so, what is the right health insurance? What is the best company or best policy? And what all other support systems should we have? And whether we should have a top up, whether we have a family floater. There were a lot of questions from some of our members. To clarify all this doubt, so we have invited three experts. Dr. Chandrakumar and Dr. Madhavan will have some small presentations. After that, we'll take up the questions and Dr. Saktesh will moderate the session. Over to you, Saktesh. Satish, you have to unmute yourself, Satish.
Thank you, sir. And as sir rightly pointed out, as doctors, we are very poor when it comes to taking care of our own health and as well as financial awareness. We are very bad. We should accept that. And this COVID just highlighted our lack of preparedness. So it is high time that we take care of our health and we also take care of our financial awareness. So we have three talks, and we will start with comprehensive health cover for TNGDA and IMA doctors by Dr. Chandrakumar. Over to you, sir. Dr. Chandrakumar, sir.
Yeah. Hello. Good afternoon, everybody. First of all, I would like to thank Dr. Nirmal, President Sir, and IMA Tambaram members for giving me an opportunity to present this small topic before you. Actually, I was a nodal officer for CM Insurance at Madurai Medical College for almost 4 years. And with that, once when we were in the retiring room of the doctors, we had a talk that some doctors are finding it difficult to take care of their parents when it comes to treatment, most of the postgraduate students. So that discussion slowly was growing like this, and we have now come out with a scheme called Tamil Nadu Doctors Medical. First of all, everybody feels that it is a scheme only meant for TNGDA members. First, I want to make it very clear that it is it was just the idea came out from TNGDA, and a group of doctors who are members of TNGDA have formed a group and they are separately running the scheme for the past 4 years. Okay. So anybody who has got a I'll just quickly go through the slides. So how to, okay, second slide. Okay, this is a welfare scheme of TNGDA. Okay, now I don't know. Yes, a welfare scheme of TNGDA. It's providing a group mediclaim cover for doctors, but we made it very clear that it has to include their spouse, children, parents, or parent-in-law, because we thought that some of the doctors' families are taken care of by parent-in-law who live along with them in their own house. So we want to give equal rights to everybody. But we always plan in such a way that premium is very low. It is the least among all the other premiums. But only thing is the members have to keep growing. So this scheme mainly concentrates on taking care of senior doctors and parents of our doctors. And who can join this scheme? See, presently we have monthly groups. See, every month has a group, and the last working day of the group group is initiated. That group will consist of fresh members and old members, and every month there are around 100, 200, 300 like that groups are getting formed. Okay, and when you pay from the 1st to 30th of that month, you are made to join into the last working day of that month. You will form a group, and that group will slowly keep growing. Like that we have designed. And anybody who is a member of Tamil Nadu Medical Council or a dental surgeon under Tamil Nadu Dental Council, life members of TNGDA, IMA, or any other registered association for doctors with a permanent residency in Tamil Nadu, we give preference to them. But age is not a bar to join this scheme. See, here, once again, I want to make it very clear that we invite senior doctors who are having problems to come and join and enjoy the benefits with us. But we also request them to promote most of their family, relative doctors who are younger to join the scheme, so that unless you have the lifeboat going, you cannot accommodate more people. Otherwise, the lifeboat will sink and the whole scheme will get spoiled. The salient features of this scheme is enrollment is provided irrespective of age, and when somebody joins the scheme at any age from around 26, 27 to 58, he pays the same premium every year. So irrespective of age, we are collecting the same premium, and when they cross 58 years, then only the husband and wife together, they constitute the family, and we don't add children and their parents when their age crosses 58, because we are not able to accommodate the renewal premium. And to join the scheme, we are not insisting on any pre-medical tests, and we are not asking any previous history of the patient, because if whatever illness may be there with the patient, does not become an exclusion to join the scheme. So whatever you have, you can have with you. But one thing what we do is we give a waiting period for certain procedures like cardiac ailments, cancer management, knee joint replacement, organ transplantation, some laparoscopic appendectomy, hysterectomy, like that. See, the concept of insurance is you should not know that you have a disease and you have come to get some money. So you join a scheme, run with the scheme. Whenever you have a problem, you get solved out of it. See, we give even maternity cover after the first year. A renewal, you are given 25,000 for your pregnancy as a one bolus amount. Like that, one eye cataract surgery is sponsored in this scheme with the 25,000 lump sum payment. So like this, we keep controlling the claims ratio so that we give renewal at the same price every year. Whoever gets enrolled in this policy, the doctor who is called the proposer is given a complimentary cover for 50 lakhs, and that cover will get renewed every year as they renew their main policy up to 70 years of age. So for this, there is no need for you to meet anybody, run here, there, anywhere. You can just do an online payment through using your mobile phone or in any other gadget. Once you make the payment, you download a receipt, then download the application form, and then that application form you fill up everything, then sign, you post it to the corresponding address, correspondence address for us. And once we receive, we will just give the enrollment, and we will strictly follow the waiting period. But who at the time of renewal, if you add a new member, the new member will be affected by this waiting period, but the existing members will not be affected by the waiting period. Suppose if any one of the member leaves a family, then you can also jump down to the lower slab during the time of renewal. Or if somebody joins like husband, wife, two parents, and after 1 year they give a childbirth also, immediately after the childbirth they can give a birth certificate, intimate to us, and get the child enrolled free of cost. So like this we are having, but one thing we are restricting is no member in the scheme cannot appear in more than one policy, and they should not mistake that by just adding their name as spouse, proposer, parent in many policies, they will enjoy higher premium of coverage. So the higher medical insurance. So that part we are very clear. Any member who comes in with his Aadhaar will be given a maximum of only 5 lakhs. And in our experience for the past 4 years, more than 3 lakhs itself, it is not coming. Very rarely, because of the corona also, during the whole corona period, we are proud to say that we were giving all type of claims to all our doctor families. But the thing is, some people did not get their expectations because they are paying a room rent of 20,000, 30,000, which is not possible in our scheme. But whoever got Cytec and Strom have got significant amount. We have paid up to 3.5 lakhs for corona, and all our members are happy as on date. But for corona alone, we are keeping a waiting period of 1 month for fresh members. And for renewal members, from day one, we were giving cashless claims. Okay. So the premium is based on age slab below 58 years. Family option is based on the number of parents or parent-in-laws enrolled, which you can easily understand by seeing the application form. I will show you later. So this I have told already. The change in options can be done, and waiting period for certain packages are applicable for 1 year. Okay, and then the amount has been highlighted. It is 15,000 for GST for husband, wife, and children up to 58 years. And once they add one parent, then it becomes 17,500 plus GST. Once they add two parents, then it becomes 20,000 plus GST. And when the proposer age goes above 58 years, then it becomes 27,000 plus GST. So now easily by just operating a link, you can just go into the payment gateway. The State Bank will collect particular details, and then you can directly into it. Select the options, fill in details, and then we will get who has paid the money. And after that, we will also contact you to get your completed application form. After enrollment, we will be sending the certificate of insurance, digital ID cards, and also an income tax 80D certificate immediately within 4 or 5 days. After the commencement.
He has got network issues.
Okay. I think he'll join back. So if there are any questions, we can take up, or we can go with Dr. Madhavan's presentation.
Yes, I think sir is connected back, sir.
Yeah.
We have
Chandrakumar, we briefly lost your audio. Dr. Chandrakumar, I think your network is not clear. Yeah, we are not able to hear you. Satish, you can take over.
Yes, sir.
Let him join back.
Okay, I think there is a network issue there. So we'll move on to the next talk. Dr. V. Madhavan, Secretary, FSS IMA, he is going to be talking about FSS, FBS, and FSS for health and IMA for doctors by doctors. Over to you, sir. Dr. Madhavan, sir.
Yeah. Thank you. Thank you, Dr. Respected President, Dr. Nirmal, Secretary, Dr. Sarvan Kumar, and Treasurer, Dr. Karthikeyan. Good evening. And I'm very happy to be participating in CME program of IMA Tambaram, a branch which has stalwarts like Dr. Raghavelu, sir, Dr. Balasubramaniam, Dr. Ravi Shankar, Dr. Amuda, and Dr. Karunanidhi, sir, and Dr. Yashoda, madam. And it's a wonderful opportunity for me to be participating in this CME program, November CME program of IMA Tambaram. And thank you for the opportunity. So briefly about the family security scheme of IMA Tamil Nadu State Branch. And it's a wonderful scheme, unique scheme of the doctors, and for the deceased doctor's family. And instantly it started at Erode, our home branch, IMA Erode, and it stands for all for one, one for all, and all for one. So, and since 2004, when it was launched, it's almost 16 years. And we are very proud to say that we have been able to console 816 deceased doctors' families to the tune of 125 crores. 125 crores from one scheme for one group of people, that is doctors. I think no other company could have achieved so much in so little time, and all because of the participation of almost 9,440 members of FSS. At the moment, the claim amount is about rupees 18 lakhs in scheme of FSS 1. How to become a member of FSS? So for FSS 1, the age limit is 50 years. When it started, there was no age limit. But now we have come up with an age limit of 50 years for FSS 1. And there's no medical certificate or pre-medical examination. And the non-refundable deposit depends on the age, which is very mentioned clearly in the application form. How do we contribute? We contribute rupees 200 for each deceased member's family. And the application form, along with this NRD amount, is forwarded by the respective secretary of the branch and to the FSS office, and we take care. In these COVID times, this is very mandatory that every member of IMA does join the FSS scheme to benefit. As a special measure, during these times, we are given a discount of 10% on the non-refundable deposit, and we have made sure that there is no window period for claims if, unfortunately, the member demises due to COVID. And the documentation that is required for claims is very simple and very transparent and very efficiently done. It just requires the original membership certificate, the copy of the death certificate, and the request letter from the nominee, which is being forwarded by the secretary of the local branch. The local branch secretary is involved in all these activities because he is the kingpin of an IMA branch. So we make the payment to the nominee of the deceased without any delay. That's why we request members to pay the advance statutory contribution on time. So for example, a member who joined in the year 2004 till today would have contributed just about rupees 1,40,000 to the scheme so far, but the family would be eligible for 18 lakhs claims. So such is the efficient working of FSS. The same way, members used to ask, what is benefit to me during my lifetime? So as a pilot project, we started a health benefit scheme. As a pilot project, we wanted to see how it functions. So we just started this year, and members above 80, we are giving hospital benefit scheme for any treatment in the hospital to the amount which they have contributed as AFC since inception of joining of their scheme by those members. So it's just in the early stages, and as it progresses further, this will also be beneficial to members during the lifetime. So when FSS 1 was started, there was no age limit. So people 70, 80 is also cut down on the age limit, and 50 is the age limit for FSS 1. To benefit people who are above 50 but below 60, a second scheme has been started. That is the FSS 2, and it was started in the year 2017 at Nagarkoil. So the concept is losses of few are shared by many. And many are 2,900 members of FSS 2 so far. And our target is to achieve 5,000 members as early as possible. Here, the age limit is 60 years. Again, the non-refundable deposit is according to the age. The advance amount that we collect nowadays is rupees 300 per death. So we collect for 40 deaths. So we collect about 12,000 every year. So what is the claim amount? In FSS 1, it was fixed at 18 lakhs. But FSS 2, what we are giving is around 300 rupees into the number of members joined. So it comes to roughly around just about 9 lakhs to all the claimants of FSS 2. So what are the highlights of the scheme is? So it's a specific scheme for the doctors, by the doctors. There's the ease of joining, ease of claims. Premium is minimum compared to any other insurance scheme, but we should not compare it to any LIC or term insurance, because it is gives us a mental satisfaction of helping one of our deceased members' families. Unfortunately, suddenly, an incident which shakes the foundation of a family of our medical professionals. It has no medical checkup. And in these COVID times, it is acting as a wonderful support system for the families of our IMA members. Unfortunately, we have lost 20 of our colleagues who were members of FSS in these past 2 months. For the past 3 months, we have received almost 59 claims, which is unheard of in the history of FSS. We claim the claims, the AFC that we collected this year was for 70 deaths. And as of date, we have paid for 105 members. So with the request from us to the State Council, the 26th premium of FSS 1, which is supposed to start in the month December, January, we have preponed to November, December, and we'll be coming out with the intimation letters shortly. And this is for 100 deaths, 100 into 200. The 20,000 is the AFC for the year 2021, 26 premium. And in this, I take this opportunity to request members of IMA Tambaram to pay the 26th premium of AFC of FSS 1 as early as possible, so that we could continue to give out the claims as and when they come in these COVID times. Similarly, in IMA, we have got a family benefit scheme, but this is managed by PPLSS. What it does, it reimburses rupees 1.2 lakhs for the hospitalization expenses in a year and not exceeding 60,000 per hospitalization. It's a yearly subscription, which is age related. And for this FBS scheme, we can contact Dr. Nehru, who is the secretary of the PPLSS at Kallakurchi. So we have different schemes suitable to all the members of IMA, be it FSS, FBS, PPLSS, hospital protection scheme. So let us all experience the joy of giving and join all these schemes, hoping to contribute our might to our fellow medical personnel and their families who may have suffered in these pandemic times, and let us be a support system for them in the future also. Thank you, Dr. Nirmal, for giving me this opportunity.
Thank you, sir. Now, if Dr. Chandrakumar has joined again.
Yeah, I'm ready. I'm
Okay.
ready.
So you can take over, and I think you left with the.
Yeah, just two more slides.
Yeah, last few slides.
Yeah. See, there are two different types of getting claims. One is to initiate a cashless treatment, which we are talking. In a cashless, we can do it only with places where there is a empanelment with Star Health. If the hospital is not empaneled, then we can go for a cashless reimbursement claim. So in both the things, you have to get a claim intimation number, you have to submit original discharge summary, investigation report, pharmacy bills. But we always advise people to go for cashless because it gets settled on the spot. So there is a copay which we have given in this scheme just to control the amount of claims amount. This copay will be for up to 1 lakh, you have to pay 10%, for up to 2 lakhs, you have to pay 20%, and more than 2 lakhs, it is 30%. So this copay and loading premium will control the claims ratio, and we also try to give renewal in the same price, okay, what you paid for the first year. And as far as the slides is concerned, I have given you a brief preview of how we have designed this scheme. So this scheme, you have to come inside from day one, you get the cover except for a waiting period. And to know more about the scheme and how to join, you can use the link. See, we have, are you able to see the screen?
Yes, sir.
Sir,
Yes.
you have to just click 1 minute. It's not coming, I think. Share screen. Basic. Share. Sir, I think now you can see my whole screen. Are you able to?
Yes, sir. We are able to see it.
You are able to see the whole screen.
Yes.
Sir,
Yes.
here you have a link. See, this bit.ly TNGDA Mediclaim Pay and bit.ly TNGDA Mediclaim application. So with using these two links, you can get all the information that is required for joining the scheme and going out. So if you want, I can just give a brief demo of how to do it, but files, Dropbox, Google Drive. So in my desktop, now I will show you my Telegram. In this, I'm just opening the page which we circulate to all our members. Are you able to see this page? So in this is a small flasher which we are giving. And in this, if you click this link, TNGDA Mediclaim application, so you will directly automatically to the website, to our website. From there, you can download the application form. Okay. Are you able to see? The connection is a bit slow, I think. I don't know what is really causing it. So you are able to view the application.
Share in the groups, Chandrakumar.
Yeah, I will share, sir.
Whatever
by
link
just
you are
okay, sir. And then similarly, we have a second link. And when you touch that link, then it will take you to State Bank Collector. There you have to give your details of your name, Tamil Nadu Medical Council or Dental Council registration number. Like that, when you share all those other details, then it will take you to the payment gateway where you can make payment and download a e-receipt which comes spontaneously from the bank side. After that, you fill in the application and send to us. If there is any doubt, anytime you can call any three of us, Ravichandra Prabhu, Arul or Chandrakumar. We will be able to help you in completing all your queries. Now I'm open for a few questions from all our members.
Thank you.
If anybody has a question, you can please ask me.
Okay, I think Dr. Gunashekar, sir. So you can give your, you can unmute and share your opening remarks, sir. Then we can
Anyway,
take up
good
questions.
evening, Dr. Nirmal, and of course, my old friend is there, Dr. Muthukumar. How are you, sir?
Fine, sir. How are you? How are you, sir?
He
I'm
is the
very.
youngest friend, sir.
Huh? Yeah, of course.
Don't call him old.
Yeah, not an old. I
No,
have
no,
completed
friendship is
65.
old.
I have
Friendship is
completed
old. He's
65
talking
years
about
on
friendship.
October 30th. And Nirmal,
Yes,
sorry
sir.
to say, actually, when you called up yesterday, I was hospitalized for COVID only. Okay.
Oh.
At 2 o'clock, I came back, and thanks to you, because I don't want to miss this meeting. Anyway, because it has helped me a lot of insight to get approval for me also. Though it is because Sir Chandramohan was talking about the cashless is not possible in a non-network hospital, which is not so actually. Today, when I got admitted in Highcare Hospital at Arubakam, it is not empaneled with any TPs. Fortunately, what has happened? They have returned to the branch office and got a special approval, and my bill was completely sanctioned by the insurance company. So it is highly possible to get cashless in a non-network hospital also, subject to the concurrence of the insurance company, which is highly possible. And this is the message which I wanted to give it to you, all of you.
Thank you, sir.
And going forward, I mean, this is related to the group insurance or particularly to the retail insurance you want me to talk about, I can talk about. Sir was talking about the sum insured of 5 lakhs, but according to me, I'll say the better, the higher the sum insured is always the better, because any hospitalization nowadays, it is almost crossing the bill of about 3 to 5 lakhs rupees. So better to have a sum insured of about 10 lakhs, either in the form of a retail policy or in the form of a family floater covering the entire family. A family could be a spouse plus another plus spouse plus dependents. Either it could be a one dependent or it could be a three dependent. They can also cover the father and mother. In the absence of father and mother, they can cover the parent in-laws also. So entire sum insured can be buffered into that as a family floater, for which it is the highest age member of the family will be taken into the criteria. And there is, when Nirmal was touched upon a point on the super top up policy is also there, because that is called as the threshold. We can have a base insurance of 5 lakhs, and then we can top up the policy up to 25 lakhs. For example, if in anywhere, all the insurance companies, including the public sector companies, are covering to the maximum of 15 lakhs, whereas in Star Health, it covers up to 25 lakhs. There are two plans available in the Star, it is silver and gold plan. So that, with a threshold of 3 lakhs, anything above 3 lakhs expenses, it will be covered in the super top up plan. Gold will be the ideal plan for all of us. So that is also available in the market now. And exclusive product like Corona covers policy has been come into the market. The maximum sum insured is 5 lakhs. The validity period is 285 days, because IRDA still doesn't know how long it is going, the disease is going to extend. So right now, for the group, they cover for 1 year. For individuals, they're covering up to 285 days, including the cash benefit. And the Oriental is one of the least, the least premium available in the market now, as of now. And for the group insurance, a minimum of 100 people is required. 100 employees are required, because since hospital is being a declined ratio by most of the insurers, they're very reluctant to give group insurance for the hospital industry. But of course, if you approach with a good database, and with whatever the coverages which you expect them to offer, there are people who can come and cover us under the ethics, under the medical ethics. Is there anything else?
Hello? Hello?
Yeah.
Can I add?
Yeah.
Can I add a few points?
Yes, sir.
Actually, in Tamil Nadu Government Doctors Mediclaim, we are providing an add-on policy up to 25 lakhs for members only if they like, not on compulsion. As a separate policy, which they can get through us, we have given some for 18 to 20 like that for our members.
Yeah, yeah. That is also there because it is also available.
We are giving. It is available with us.
No, I do understand. In fact, I myself having a policy. I'm having a policy in the All India Insurance, and the top of policy is in the Star Health only. So anytime once you have a base policy, because there are thresholds available for 3 lakhs, 5 lakhs like that. But my suggestion will be to go for a 3 lakhs threshold. So once expenses of the hospitalization crosses beyond the 3 lakhs, the top of policy will come into play. But usually there will be a doubt because for any single hospitalization, everybody will have a doubt. Two cashless is not possible, but that is not so.
Yes,
We
sir.
can still avail. We can still avail two cashless, subject to the concurrence from the first insurance. It could be either it could be any private insurers or a public sector companies. The only thing is they have to give an NOC saying that they can automatically give provided because the submission of bills will be the problem there. That is up to the hospital to take it up with the respective insurance and submit the documents for claiming their amount. So that is highly possible.
In Tamil Nadu Doctors Mediclaim also, we are giving this facility, sir. Not only with the same company, even they can have with some other company also, we can substitute with our policy. That is what. But we have to get the settlement letter original from the previous primary insurance.
For which we can
and
get
we also
NOC.
have a threshold of 3 lakh only. We are not having a threshold of 5 lakh as you say.
For which the NOC from the first insurance, because see, suppose if I'm applying a cashless in HDFC Ergo, once the sum insured has exhausted or anything over and above threshold, the HDFC will give an NOC to the hospital so that automatically the second insurance will come into play. The hospital can upload all the documents for cashless and avail cashless before getting the discharge. That is highly possible there. And the way of submitting the bills is also more important actually.
But in this group, which I would like to mention is, because I am personally talking to all the members or whoever inquiries are asking me, there are so many people who are, even though we are starting from day one cover, there are so many people that, asking me that now I have this problem. Can I join insurance and can you give money immediately? This is still being asked by many people are asking this question, but insurance should become a habit in daily life. That should be promoted among our doctors. This is my humble request.
Yeah, I'll understand with you. To avoid such thing, the group mediclaim is one of the best option available in the market. Because GMC policies from day one is covered now, and including the critical ailments also. We can easily see almost about 12 to 15 number of critical ailments, which is more common in orthopedic and neurospinal. So those ailments can be covered under the group insurance, and from day one onwards, it can be covered. And always, even yesterday, I was handling a group mediclaim policy, which personally I underwrote the policy. So what has happened when the employee was inducted into the corporate because he was having a CU esophagus, addition was done, and the insurance company gave the endorsement. And yesterday evening, he got approval in the Apollo Hospital for CU esophagus. So that is also possible in the group mediclaim policies, which can be done. Any addition, deletions are possible in any group mediclaim and day one covered, and whatever, because it's only tailor made. So whatever we wanted to cover in the policy, which we can take it in the group mediclaim policy.
We have a question from one of our members here. Is there any scheme for seniors nearing 70 years? And do you have any scheme for IMA doctors in association with Star Health Insurance?
Sir, actually, Mediclaim, Tamil Nadu Doctors Mediclaim, this policy gives entry for non-TN Tamil Nadu government doctors, IMA members, not even IMA members who even if they are registered in Tamil Nadu Medical Council, they can come and join us and we are giving services. But only thing is when they cross 58, they can come only with themselves and their spouse. They cannot add their children or parents as you do when you are less than 58 years of age. This one restriction is there. Otherwise, you can jolly well come and join our scheme.
I think that is called as a senior citizen red carpet policy. Am I right? It is called as a senior citizen red carpet policy.
It is not like that. Basically, even if somebody who is less than 58 years wants to include their parents or 80, 70, we are allowing. So it is only we are collecting a premium without any administrative cost or anything, and we are trying to share it to all the facilities to all of them. So far, we are able to manage with the same premium which we gave on day one when we initiated the policy. Up to 4 years, we also succeeded in giving renewal also at the same cost. So I think we will be able to manage when more and more members are coming and joining into the scheme.
Yeah, even in the public sector companies in New India, they are offering a policy called national. It is called as a Parivar policy, whereas in New India it is a 50 lakhs and global mediclaim is also being issued by New India, where the global coverage is there, and with an air ambulance and other all facilities are integrated into that policy, subject to the underwriting, because we have to submit ourselves for a battery of tests, and then the underwriting office have to give approval for that 1 crore policy, which is also available in the market now.
But we are not insisting on any medical tests or any previous. We don't even ask the previous history of the proposer or any of the family members, because we know usually everybody they are going to get the disease and everything. But we are giving a waiting period so that we will be able to manage the claims, because every year we give around 1.5 crores of claims to people. So far, we have given almost 6.5 crores over the past 4 years. So this is not to boast the efficiency of the scheme, but we are doing a lot of goodness to everybody. Maybe we might not, because as we are getting very low premium, we will not be able to pay luxuriously to our members. But we are definitely taking care of people, and we have every year around 1.5 crores we are giving as claims, approved claims to various members for their disease.
Yeah, my request to the members also, because the out-of-pocket expenditures at the time of discharge is more important. Even in spite of having insurance, there is a study but done by few corporates. Almost about 22%, they are paying, their employees are paying as a over and above as an cost, additional cost to the hospitals. Again, you can call it as an out-of-pocket expenditure. In spite of that being co-payment and every other clauses are there, my request, where we can address something to minimize that particular out-of-pocket expenditures to a bare minimum of 5 to 10%. So that
Sir,
we can work it out.
Yes, sir. As far as ours is concerned, we are very clear with what we give to the patient. So we are giving 1% as room rent, maximum 12% to 15% as professional fee. Like that, we have given everything to the patient well in advance, even at the time of enrollment itself. So they are pretty aware of what they will be able to avail from this policy.
That is the reason I've been insisting.
Second thing is, a 5 lakh policy is for 6 members. So whatever may be the claims made for an individual, we would not like to exhaust the full in one admission. So we would like to reserve some money for the follow-up for the same patient, or any other member goes critical at some time. They will not be able to immediately arrange next huge sum. So we would like to spread that 5 lakhs for at least 2 or 3 admissions in a family.
Yeah, that is why I've been insisting go for a higher sum insured. So either ideally, looking at the medical inflation these days, I think better to go with either 10 to 20 lakhs of policy, sufficiently in hand will be much better, like for community, like doctors like us. And
Sir,
today
actually,
I was a standing example today. When the bill came for 1.95 lakhs, I was really panicked. I don't know how much I'll be getting it. And of course, thanks to my previous organization, almost about 1.81 lakhs has been sanctioned to me today evening. And hospital gave me some discount, and without any paying anything, I just came out of the hospital. So that is why I'm telling
yeah. But it doesn't happen to us, for common man. We become common man in front of the insurance.
Sir,
it is not
we are taken for granted, and then they speak rules. When they have this cashless, then they have to go and reimburse. That's the only word, and that one line letter is the end of that. and we
You
cannot
give
go
the claim
further.
to me, sir. I will do that for you,
Sir,
sir.
sir, actually,
I'm there to support you, sir. I'm
No,
free
no,
now.
Thanks,
not
thanks.
only that, no, it's thank you for that, but every patient, they're also feeling the pinch when they
sir, actually,
pay
to
the
understand
policy.
better, our scheme, if husband and wife both are doctors, they take two policies, including their parents and parent-in-law separately. They can easily raise their mediclaim coverage to 10 lakhs and personal accident to 1 crore. Over and above, they can get 25 lakh add-on policy. I think this is more than enough for any family. Second is, we also have a back thought in our mind that we should not unnecessarily collect more money from our members and pay to the insurance company, because we are not doing it for
So
business.
in that
This is a very important concept which we want to speak out. We are not interested in collecting more money and giving to more company, but at the same time we are able to live up to the expectations of our members to a very great extent.
Yes, sir. Dr. Chandrakumar, I have a question.
Yes.
What is the
Yes,
claim
sir.
ratio, sir? In our hats off to your effort. It's a great one.
Somewhere around 110, 108 to 130,
Okay,
we are
then
oscillating.
I agree. You are serving the doctors. One occasion.
Always a building portfolio, sir.
Otherwise, doctors are making money for insurance companies, sir. Hospitals are making money for insurance companies.
Sir, far as
But,
far
I
as
should
our
thank
scheme
Dr.
is concerned,
Chandrakumar for
110,
having
sir.
broken that rule and helping the doctors out.
Thank you,
If
sir.
it's 110% claim ratio, it is really a good job. Thanks to you, sir. It's a great effort.
Only because of controlling the claims ratio to that an extent, we are able to renew the same premium amount every year.
Because my question was to ask you about co-payment, but since you are
Yes.
saying 110 claim ratio, my question is stopped. I cannot ask you that.
Sir, actually co-payment in a way controls the amount that is paid by a member at the time of discharge to the hospital. Once we restrict, when we ask them to create a habit of making a co-payment, he goes and starts bargaining with the hospital and tries to restrict the bill. That we have seen. When people cross from 1 lakh to 2 lakh, they automatically go and try to bring it to 1 lakh. So their
But
co-payment ratio will come down.
to be frank, you are putting the entire burden on the hospitals. Already the insurance package is very low, right?
Sir,
But putting the onus on co-payment and patient to bargain again, so we
it
end
is
up fighting with the patient and their attenders
no.
rather than providing care.
I individually take up all the calls from all doctors and I keep
No,
handling all the issues.
Chandrakumar cannot be there everywhere, no.
No. They call me.
You can't
Everybody,
expect Dr.
no.
Gunashekhar or Dr.
No,
Chandrakumar
whenever somebody is in a difficulty, they will call me freely. That is how I have all my members. But what I want to specifically tell you is, it is a scheme run by doctors and run for doctors, and the hospital is also serving for doctors. So you can take it that way also, no?
No,
You
that
cannot,
is okay.
Co-payment
the
is
same.
a real sore on the pocket, sir. Definitely, and it will indirectly hit the
But
hospitals, as Nirmal said.
like if you come and see during the discharge, it's such an unpleasant way of dealing with patients, right? We'll provide good care and patients are happy, but the fight is with the insurance team, administrative team, and the patient attender that spoils the entire relationship.
Exactly.
Yeah,
After
that is the.
all the
No,
good
I'll
work
agree
done
with
is
you.
lost.
Because invariably this happens during discharge. The doctor will say you can get discharged in the evening, but the bills are not paid. Then starts the entire issue.
Sir, actually, we before taking a decision on this call, I always ask them to give the breakup of the bill. I examine the bill, then only start speaking about it. Without examining, without knowing what is what, I never make any comment on those bills.
No,
Only
okay.
after seeing everything, then we also try to negotiate with the company, try to do some goodness to the hospital also. But your point is well taken, sir.
Thank
It
you.
is
I
not
think we
all
are
the
deviating
hospitals,
a
sir.
bit from the group health insurance coverage for doctors to the problems of hospitals. But are there any other good insurance policies? Because you spoke about TNGDA and doctors insurance, and sir was telling about some other private insurance and FBS scheme of IMA. Are there any other policies particularly for doctors? How about this HDFC Ergo and few other premium policies?
Sir, actually, there are a hell lot of policies that are available in the market. You can just browse online and see. Hello?
Yeah,
Am I
yeah.
audible?
Go ahead, go ahead.
Yes, sir.
There are so many number of insurance companies and there are so many quotations, there are so many conditions. Everything is available online. You can just go browse through. But when you have a problem, you have a single person contact. That is what we are providing in TNGTA Doctors Medical. So any member will not hesitate to call me any minute, and a doctor is represented by another doctor to the company, and this sort of relationship we cannot have in other companies. I don't know. Some of your members will be there who would have enjoyed this relationship also, because we are considerate towards patients, hospitals, and our doctors community.
Okay. Thank you. Thank you.
Yes, sir.
So, I think there are any questions, Saktesh?
There is only one question which came from you, sir, that needs to be asked. What about group policy for hospital staff? Is it true that insurers are avoiding group policy for hospital staff?
With my experience, because they had some bad experience across in the state, so that is why normally they have put that into as a declined ratio. Whereas if the members are sizable, and maybe it should be about 100 plus, so that we can definitely approach our insurance, particularly both the public sector companies as well as Star also. We can apply for the group insurance with a decent coverage. That is highly possible.
Sir, actually, I would like to add one point. There are some companies or more hospitals who make a claims ratio in one insurance company, and when next year they migrate to the other company. So this habit of migration based on the quotes at the time of renewal is causing problems, and it is spoiling the reputation. So when we have a long-term relationship with the company, I think they will be able to give it to you.
But with a good underwriting, we can cover, sir. With
Yes,
a good
sir.
underwriting, we can definitely take the confidence of the hospital, and definitely right from day one onwards, we can, because it's a joint exercise by the insurer and by the provider. We can have a better control on the ICR.
Yes, sir.
See, when you're talking about 110 and all, definitely we can have a better negotiation with the provider, so that their premium is going to be lesser in the next year.
Yes,
it is not going to be get loaded.
Yes, sir.
Okay.
So I thank all the members, organizers, and IMA Tambaram for giving me an opportunity to share my few experiences in this TNGTA Mediclaim. I invite you all to come and join us. And thank you. Thank you, Dr. Nirmal.
Thank you. Thanks.
Thank you, everybody.
Thank you,
Dr.
sir.
Nirmal.
Thank you for your wonderful work, and so thank all the speakers, Dr. Gunashekhar, Dr. Madhavan, Dr. Chandrakumar, for their valuable inputs. I think members, if you have any queries, you can contact them. So if there are any queries, you can also put up in the IMA groups. Maybe we can get the answers from the experts and share it with you. But the point of having this discussion is, please have a health insurance with adequate coverage. Whichever company you go for, understand the policy, understand the risk factors, and then take a policy. So I think, Shaktesh, you can give your closing remarks.
Thank you, sir. So it was overall a very good, enlightening talks, and particularly this TNGDA insurance scheme is one of the most transparent and well-covered insurance policy, particularly for doctors. And as Dr. Gunashekhar sir rightly pointed out, if we have sufficient numbers, we can go and approach as a group and form a group health insurance policy. So thank you everyone for your input, sir. Thank you very much.
Yes, sir. Thank you, Nirmal, and everybody.
Yeah, thank you.
Sign off.
So we now have the vote of thanks, Dr. Karthikeyan.
Yes, sir. Good evening, sir. Am I audible?
Yes, yes.
Yes. Good evening, the learned members of IMA Tambaram. It was a highly informative CME program on latest trends in orthopedics and panel discussion on health insurance for doctors in hospitals, organized by IMA Tambaram. Sincere thanks to the speakers, Dr. T.K. Vinod Kumar, Dr. Naresh Kumar. Heartfelt thanks to our most respected Dr. Muthukumar sir, who is gracious enough to take part and support this program. Thank you, sir. Thanks to the panelists, Professor Chandra Kumar, Dr. Madhavan, Dr. Gunasekharan, for highlighting the importance of insurance for doctors and hospitals. Thanks to Dr. Shaktis for coordinating this panel discussion very lively. Thanks to Dr. Gunasekharan. Thanks to our President Secretary for offering me this opportunity. Thanks to all the participants for their valuable time. Thanks to Parvati Hospital for supporting this program. Thanks again to one and all.
Thank you.
Thank you, sir. Thank you.